Hello, today with this FERNE presentation we will be discussing the care of emergency department patients with dizziness and vertigo in an attempt to appropriately diagnose and treat patients with a potential serious central etiology. My name is Edward Sloan. I'm an emergency physician in Chicago. I work with FERNE, the Foundation for Education and Research in Neurological Emergencies, ferne.org. I have no financial conflicts. I'm the FERNE president and board chair. Let's now consider the bedside physical exam. Again, we refer to the timing and triggers approach, monograph by EB Medicine, written by Jonathan Edlow, an emergency physician who has a specific interest in dizziness. If you look then at the clinical pathway for evaluating patients with dizziness and/or vertigo, there are 5 findings on physical exam that need to be considered for all patients in whom a central etiology is possible related to their dizziness or vertigo. Because patients with acute vestibular syndrome could have a posterior circulation stroke, and because patients with spontaneous episodic vestibular syndrome can have a posterior circulation TIA, it is essential that for all patients with either continuous vertigo presenting at the time of evaluation or for those with episodic vertigo, that we perform 5 physical exam tests specifically to evaluate possible central causes. Now bear in mind, a general physical exam needs to determine whether or not the patient is a vasculopath, whether they have adequate pulses, whether or not they have a cardiac dysrhythmia, whether or not they have an abdominal aortic aneurysm, for example. But once you've done this general physical exam, we are now going to focus on the exam related to the patient specifically with dizziness and vertigo. Now, the first thing you need to do is to examine for nystagmus. Why? Because the head impulse test, which we'll be talking about, is really most useful only in patients who present with some type of nystagmus. So the first thing we'll do is to check for nystagmus, trying to note where the fast component is. Then we're going to do a head impulse test, and we'll talk about that. Then we're going to check for vertical skew deviation. Then we will check for stroke exam findings, including new hearing loss, which can be assessed by rubbing the fingers by the ear to determine whether each ear has hearing that is adequate. And lastly, we'll check for ataxia, whether that's truncal ataxia and/or ataxic gait or cerebellar ataxia. So if any of these 5 findings suggest a central etiology, then a posterior circulation stroke or ischemia are possible and/or likely. And we're going to talk more about these specifically in a moment. So what are the findings that would suggest a central etiology to profound vertigo, either spontaneous and intermittent, or patients with constant dizziness present at the time of evaluation, acute vestibular syndrome? What are those things that would make you consider a central etiology? The first, central pattern nystagmus. That is nystagmus that is not just related to a peripheral vestibular system malfunction. The second would be negative or no corrective saccade on head impulse test, and we will talk about that. If there's some skew deviation vertically, it means the pupils are not aligned adequately on the horizontal axis. That would suggest a central etiology. If there are any findings on neurological exam, including hearing loss, that would suggest a central etiology. And lastly, if the patient's unable to sit in the cart without veering to the side or cannot walk unassisted, that also would suggest a central etiology, a possible posterior circulation disruption, vertebral basilar insufficiency. Those patients need to be red lighted, considered for admission and further evaluation. So in Table 2 from the monograph, the 5 physical exam findings are listed here, In green are those findings that would suggest a peripheral etiology, and then in red are those findings that would suggest a central etiology. I would recommend you take a look at this monograph. It's a good example of what EB medicine does. Dr. Edlow specifically lays out much of what we're discussing in the tables and the text of this monograph. So now let's talk specifically about how we examine the patient with vertigo and try to establish a peripheral versus central etiology. The first thing we're going to do is to consider nystagmus, and I will refer most to those patients who present with acute vestibular syndrome, those patients who present to the emergency department with continuous dizziness that is present at the time of evaluation. How do we assess nystagmus in these patients? First off, as I mentioned, nystagmus is related to patients with acute vestibular syndrome. In other words, this is the most reliable time where you can determine whether nystagmus is central or peripheral, especially relating to a central cause related to posterior circulation disruption. The nystagmus exam in patients in other clinical settings will vary, such that these central versus peripheral tenets may not apply. In other words, what I'm about to discuss regarding nystagmus is important to be considered most in acute vestibular syndrome patients. The second, nystagmus is discussed first in our HINTS exam because the horizontal impulse test results only apply to those patients who are demonstrated to have nystagmus that could be related to a peripheral etiology. The third point or caveat prior to going on to discussing nystagmus is the following. If a patient presents profoundly dizzy, they have vertigo, they say they cannot stand, they cannot open their eyes because they have such profound vertigo with motion symptoms. If this patient does not have any nystagmus in the setting of profound vertigo and ataxia, a central etiology should be suspected regardless of any other parts of the HINTS exam. Why is that? If you are going to say a patient who is profoundly vertiginous has a peripheral etiology, they need to have some nystagmus in order to suggest that their abnormal eye movements is related to disruption in one or the other vestibular system. If there's no vertigo whatsoever, it is likely a central etiology to the vertigo symptoms. So now let's consider nystagmus in acute vestibular syndrome and whether it's peripheral versus central. In green, peripheral etiology, we know that with a peripheral etiology to acute vestibular syndrome, patients will commonly have horizontal nystagmus, and that's okay. That's expected if one of the vestibular systems does not keep the eyes aligned with head movement, for example. What type of nystagmus is common and okay in a patient with a peripheral etiology? The fast movement needs to be only in one direction. In other words, nystagmus related to a peripheral etiology, the nystagmus, the fast component that corrects, is only in one direction on the horizontal plane. So what, therefore, are the findings of nystagmus that suggest a central etiology? Number one, as we discussed, if there is profound vertigo and the patient has no nystagmus whatsoever, no horizontal nystagmus whatsoever, you should consider a central etiology, because if one of the vestibular systems is malfunctioning, it should cause some component of horizontal nystagmus to be observed. Other findings consistent with the central etiology include vertigo, Okay, so I'll start 3, 2, 1 with other. Other findings regarding nystagmus that are consistent with the central etiology include the following: vertical nystagmus. Nystagmus vertically is not normal, is not to be considered a normal finding in acute vestibular patients who present with vertigo. Torsional or rotational nystagmus, which sometimes we observe in patients who take PCP, for example, is another example of central etiology in nystagmus. Also, if the fast component is bidirectional, that is to say, fast correction to the left, fast correction to the right, bidirectional horizontal fast nystagmus movement should be considered to be a central etiology. Why? Because it's not likely that both vestibular systems are going to malfunction at the same time. So if you have fast correction to the left and to the right, consider a central etiology. This is a pictorial representation from the monograph we've discussed. So, in summary, central etiology, no horizontal nystagmus whatsoever, or vertical or torsional rotational nystagmus, or horizontal fast component correction in both directions. And this is an example in red in the picture of fast component correction in both directions that would suggest a central etiology. So, central etiologies for nystagmus: no nystagmus whatsoever, vertical or torsional rotatory nystagmus, or bidirectional fast component nystagmus. Peripheral unidirectional horizontal fast nystagmus, suggesting that one vestibular system is sick. Now that we've discussed nystagmus in acute vestibular syndrome patients, if there is horizontal nystagmus and you're trying to determine with some degree of certainty that the horizontal unidirectional nystagmus is due to a peripheral etiology, we then move on to the head impulse test. Again, this test is most useful in patients with nystagmus. If the patient has no nystagmus whatsoever, consider a central etiology. What we're looking for on the head impulse test is an asymmetry in the vestibular response. So what is done is, with the patient who has vertigo with acute vestibular syndrome in the emergency department, you move the head 15 degrees to the side and then quickly move the head to the center. If there is a peripheral etiology to the nystagmus and to the acute vestibular syndrome, if there is a peripheral etiology, one of the sides should have some component of Dahl's eyes on this acute oculovestibular reflex, and there should be some corrective saccade. In other words, on one of the two sides, with movement to the center rapidly, the eyes should lag a bit and there should be some correction to the center because one of the two vestibular systems is malfunctioning. If, however, there is no correcting saccade on either side, that means both vestibular systems are working correctly. If you don't see a correcting saccade on either side, then it's not likely that there's a peripheral vestibular problem, and therefore the vertigo could be central in etiology. If we go to figure 5, page 12 of the monograph, it shows how the eyes follow rotation to the disease side with the correcting saccade to the center. In other words, if there is a peripheral etiology, with movement ahead to one side, the eyes will tend to go with it, and when movement back to the center, the eyes won't come back as quickly and they'll need to come back on their own. This correcting saccade is evidence of a peripheral etiology. If there's no compensatory saccade on either side, then the vestibular systems are working normally, and think a central etiology. So on this head impulse test, a central etiology again is suggested when there is no unilateral saccade observed on either side, suggesting no dysfunction in either vestibular system. So from the timing and trigger monograph, we come then to the language that discusses the head impulse test. Again, it's performed in patients with acute vestibular syndrome, continuous, present at the time of evaluation, with some component of nystagmus. Centrally, if there's no saccade in either direction, that's worrisome. It's not correct. It means that there's likely a central etiology because there's no vestibular dysfunction. If you do see a unilateral eye saccade, which is a correction to the center, this is actually good because a unilateral saccade suggests that one of the two vestibular systems peripherally is malfunctioning. So we conclude the head impulse test. Again, centrally, no saccade in either side or either direction of head movement means there is normal vestibular function bilaterally. If the eyes stay midline when you move the head back quickly, if there's no correcting saccade, that means the vestibular systems are working correctly and a peripheral etiology cannot be determined, and then you must think central. The only way to say there's a likely peripheral etiology in a patient with acute vestibular syndrome on head impulse test is that with rapid movement back, there's a correcting saccade on either the left or the right, meaning that one of the two vestibular systems is malfunctioning. Now that we've discussed nystagmus and the head impulse test, we will talk now about the test of skew in order to determine whether or not there's a peripheral or central etiology to the cause of the dizziness and vertigo. So the test of skew. The skew test is determined by keeping one eye covered, but then intermittently covering and uncovering one eye. If it is a peripheral etiology, there will be no vertical skew deviation to get the pupils lined up on the horizontal axis. In other words, when covering and uncovering the eye, there will never be a vertical movement to make the two pupils line up on a horizontal line. If there's any skew deviation, and that with covering or uncovering you see one of the eyes moving to correct, if that vertical movement is noted in either eye, when one or the other eye is uncovered, that would suggest on test of skew a central etiology. This is somewhat similar to having vertical nystagmus, where the eyes, the pupils tend to drift off on the vertical axis. So this test of skew, where there's correction on the vertical line, is a bad finding in acute vestibular syndrome patients. So a positive central test of skew would be some movement on the vertical axis to get the pupils to line up when covering and uncovering each eye. It's circled in red here from the monograph. So in conclusion, test of skew, a central etiology are where the pupils are misaligned vertically, and when you cover or uncover an eye, the pupils will move in a vertical line to get there to be alignment horizontally. A peripheral etiology can be assumed if there is no need for the pupils to line up or no vertical movement so that the eyes align on the horizontal axis. So now we've talked about nystagmus, head impulse, and tests of skew. Now let's just talk about the neurological exam and how it helps us to determine the difference between central and peripheral vertigo. A neurological exam that has no specific findings then supports a peripheral etiology. If there's no cranial nerve, brainstem, or cerebellar findings, you then can say it's likely a peripheral etiology. So what are some central findings? Limb ataxia, that is abnormal movement, heel to shin in the lower extremities, or finger to nose in the upper extremities, or the dysmetria that doesn't allow you to rapidly turn over your palms in either upper extremity. So the inability to move the limbs appropriately would suggest a central etiology. Dysarthria, the inability to move the mouth correctly, suggests a central etiology. I have here on the slide hearing loss in red because the Hintz Plus exam, Hintz Plus, the plus was assigned by Dr. Newman Tokar, and it refers to hearing loss as an additional finding that adds to the ability of the exam to determine a likely central etiology. Also, when checking on the neurological exam for a central etiology, pain and temperature sensory loss must be determined. I put a few asterisks here because most people check for light touch, but actually if you're trying to determine posterior circulation, TIA or stroke related to vertebral basilar insufficiency, you do need to check for pain and temperature sensory loss, not just light touch. Lastly, some other findings that would suggest a central etiology to vertigo would be diplopia, any component of double vision, any ptosis that could involve a third nerve compression, anisocoria, which is a difference in pupil size, and or dim vision, which could be related to posterior circulation insufficiency. So, on neurological exam, central findings include ptosis, unequal pupils, hearing loss, brainstem findings, pain and temperature sensory loss, dim vision or dysarthria. Cerebellar would be limb ataxia findings. Peripheral would be no abnormalities either in the cranial nerves, brainstem or cerebellum. Lastly, when considering a patient who presents to the emergency department with vertigo, consider peripheral or central findings such as truncal ataxia and ataxic gait, which would suggest a central etiology. So a peripheral exam or a peripheral etiology that could be assumed for the vertigo requires that there be no findings when checking for truncal ataxia or ataxic gait. Central etiology should be suspected if the patient's unable to sit without holding on or leaning in the cart, or if the patient is unable to walk unassisted. In other words, they have truncal ataxia or ataxic gait. So again, to summarize, central findings, truncal ataxia, leaning when sitting, ataxic wide base gait when standing or walking. If those are not found, then a peripheral etiology might be the cause of the patient's acute vestibular syndrome and vertigo. So we've gone through the 5 exam findings that are required in patients who present with profound vertigo, the acute vestibular syndrome. And we'll talk now about the negative big 5 on the Hintz Plus and the Plus exam, which I've added. So, on the Hintz Plus exam, which is head impulse, nystagmus, test of skew, plus hearing loss, I've added an additional plus in parentheses just to cover truncal ataxia or ataxic gait. What would suggest a central etiology in a patient with vertigo and acute vestibular syndrome? Number 1, vertical, torsional, or bilateral fast component nystagmus. Number 2, a normal head impulse test bilaterally, meaning there's no corrective saccade on either side, meaning neither vestibular system is ill and malfunctioning. If there's vertical skew correction to get the pupils to line up horizontally, that would suggest a central etiology. Then central neurological findings, limb ataxia, dysarthria, hearing loss, which is the plus in the HINTS Plus exam, pain or temperature sensory loss, diplopia, ptosis, anisocoria, dim vision. And then I've added in parentheses truncal ataxia or ataxic gait, because those are also relevant to posterior circulation ischemia or infarct. And I also add any findings that are related to anterior circulation stroke, such as unilateral extremity weakness, facial asymmetry, aphasia, or altered mental status. So, to reiterate, what are those findings that red light a patient's exam suggesting a central etiology? Bilateral fast component, vertical or rotational nystagmus. A head impulse test with no correcting saccade on either side. A test of skew that has some vertical component correction to get the pupils to line up on the horizontal axis. Hearing loss, truncal ataxia or ataxic gait, and or anterior stroke signs. If any of these are observed, you know then the patient needs to be red lighted, considered for a central etiology to the vertigo and acute vestibular syndrome, and admitted for further testing. Alternately, what are the big five that will allow you to exclude a central etiology and then say it is a likely peripheral etiology to the acute vestibular syndrome and vertigo? So, in order to clear the patient and to get a green light to go, you need to have the following. In a patient with unilateral horizontal nystagmus that is unidirectional, that is, the fast component is only in one direction, not both, you then have to have one side that has a corrective saccade that would suggest that one or the other vestibular syndrome or system is malfunctioning because it is ill unilaterally. You also need to have the pupils aligned, no vertical skew. You need to have no posterior neurological symptoms, no hearing loss. The patient needs to be able to sit, stand up, or walk. And then you need to have no anterior stroke signs, no weakness, no unilateral face findings, no speech abnormality, no altered mental status. In other words, this is the HINTS Plus exam listed at the bottom of the slide. The most important thing that I think you can learn today from all of this information regarding dizziness is circled here in red. In order for you to say it's a peripheral vestibular problem, one side needs to have a correcting saccade, meaning that one or the other vestibular systems in the ear is malfunctioning. On this slide, again, we reiterate what are the positive findings that would suggest a central etiology to the vertigo and acute vestibular syndrome. And one of the most important would be on head impulse that there's no corrective saccade on either side. So in other words, in order to make the diagnosis of vestibular neuritis in a patient with vertigo and acute vestibular syndrome, you need to have the following. You need to have unilateral fast nystagmus in one direction that suggests one of the vestibular systems is malfunctioning. You then need to have a unilateral saccade on head impulse test, where if you move the head, there's a correcting saccade on one or the other side in order to prove that one of the vestibular systems is malfunctioning. Remember, if there's no nystagmus whatsoever in a patient with acute vestibular syndrome, you need to assume a central etiology. And if there's no unilateral saccade on either side, you need to assume it's a central etiology. And with that, I say thank you. For any further information, I encourage you to go to FERNE.org, or we can go to the FERNE.org channel and subscribe on YouTube, or you can send us an email at fern.org@gmail.com. Thank you for your time and attention to this important clinical information related to the neurological emergency of acute vestibular syndrome in emergency department patients. I'm Edward Sloan. Again, thank you and have a good day.